Hi, everybody. Welcome to the 92nd Street Y. I love the fact that they named this event tonight, Knowledge is Power, because that's been my mantra as I go all over the United States talking to different groups to educate them. And tonight it's especially meaningful because when it comes to the BRCA gene mutation, if you don't have the knowledge that you might be a carrier, then you don't have the power to perhaps save your life. When we speak about the BRCA mutation, we have a wonderful panel here tonight to help explain the BRCA1 and BRCA2 gene mutations, which greatly increase your risk of breast cancer and ovarian cancer and pancreatic cancer and prostate cancer, even melanoma. And disproportionately, it affects the Ashkenazi Jewish population. And we welcome all of you here tonight. I want to start tonight really kind of at the basic question of the BRCA gene, because we all have the BRCA genes, correct? And the risk of the mutation.
Sure. So there are two genes, BRCA1 and BRCA2, and they really just stand for breast cancer 1 and breast cancer 2. So it's not that creative, but that's how they were named. And we all have these genes, and these genes in our normal healthy cells help repair DNA damage, a certain type of DNA damage where both of the strands of DNA are broken. So if you're born with one bad copy of BRCA mutation, you have a much increased risk for developing breast cancer, up to a 50 to 70% lifetime risk, ovarian cancer, which is a higher risk for BRCA1 than BRCA2, but up to 45%, and then particularly for BRCA2, risks of pancreatic cancer, bad prostate cancer, and also melanoma. So it's really worth knowing that you have one of these mutations.
And if you have the mutation, you also can develop cancer at a much younger age. And is it a more aggressive cancer in many cases?
Yes, so the age of onset of breast cancer, so the average age that women develop breast cancer, is much younger in BRCA1 and 2 mutation carriers. And particularly for BRCA1 mutation carriers, the breast cancers are usually triple negative, which you unfortunately know about, which is estrogen receptor negative, progesterone receptor negative, and HER2 neu negative. And until recently, which we'll talk about later, until recently, the only treatment for that type of cancer was chemotherapy. We didn't have options to treat with hormones. We didn't have options to treat with a drug called Herceptin. But as you'll hear about later, we now have a new exciting option for BRCA-related triple-negative breast cancer.
And Dr. Robson, maybe you can take us to the point of how do the mutations run in families?
Yeah, so we all have two copies of both the BRCA1 gene and the BRCA2 gene in all of our cells. And one of those copies comes from our mother, and one of those copies comes from our father. And when we generate sperm or eggs to have our own children, each, we call them germ cells, contains just one of those. It contains either the copy that you got from your mom or the copy that you got from your dad. So your child can inherit one of the two sort of randomly because they get the other copy from their other parent. So if you carry a single mutation in BRCA1 or BRCA2, it's present in all the cells of your body, including half of your germ cells, half of the sperm or half of the eggs. And then that can be passed on with a 50-50 chance to any child that you happen to have.
I even have friends, though, that ended up being BRCA positive, and they found out too late because they only looked up the mother's side. So, but 50% of carriers are men, correct?
That's correct. And so therefore 50% of carriers got the mutation from their fathers. And that was something that took us a long time to communicate, I think, to the community, was that because it was breast and ovarian cancer that were the most prominent types of cancer, everybody thought, well, then it must be coming down from the women's side. And that's simply not true. It can very much come from the men.
And I still think it's still underappreciated. Still, people don't really look at their dad's side of the family. Still, physicians aren't asking about dad's side of the family. So we still have work to do in that area.
Well, physicians probably at this point really aren't asking enough questions, period, about ancestry.
Well,
Is that a fair thing to say that we have to kind of tackle a little bit?
And I think we'll get into that, and Nicole and Elizabeth, I think we'll certainly take that on.
Well, because if you drill down even more, obviously, those of Ashkenazi Jewish ancestry are even more pronounced risk, disproportionately. want to talk about that?
For sure. So when we look at the general population, we see that BRCA carriers, the frequency is about 1 in 400. If we focus specifically on the Ashkenazi Jewish population, the frequency of having a mutation, if you're Ashkenazi Jewish, is 1 in 40. So that's 10 times more at risk to carry one of these mutations. And that's because there are 3 common mutations that run in the Ashkenazi Jewish population that account for about 95% of the BRCA mutations in that population. These are called founder mutations. They're very ancient populations that arose in the Jewish population, and they were rare originally, but then as the population shrunk due to various bottlenecks or population started to migrate, these populations then carried that mutation at a much greater frequency, and then when they continued to inbreed or stay geographically isolated, they became more frequent.
But since that time back in Poland 500 years ago, when this, was really just kind of percolating just in this little community, these days, in this day and age, I mean, the Jewish people have gone all over the world, they've intermarried. If you don't know that much about your ancestry, and I don't know if everybody really understands exactly the nuances of their ancestry these days, how do you go about genetic counseling when someone doesn't really know that much, not only about their ancestry, but many times they don't know that much about their family medical history?
Yeah, so let's talk about ancestry first. So for purposes of this kind of test, if you have one Ashkenazi Jewish grandparent, you're considered Ashkenazi Jewish, no matter how much intermarriage there was, no matter how much Sephardic Ashkenaz blending there was. So that is one point to take into consideration, that just one Ashkenazi Jewish grandparent can turn the table here about whether you would be somebody who should consider testing for the Ashkenazi Jewish mutations.
But as I understand it, this mutation can be silent for several generations. So if your grandmother didn't have breast cancer, your mom didn't have breast cancer, your aunts didn't have breast cancer, what would make you all of a sudden suspect that you should be worried about this?
Right, so this is the second question, which is the question about family history and family medical history, and what do you know about your medical history? And unfortunately, there are families where it's really hard to discern what the family medical history is. Sometimes the families are very small, there's a limited family structure. Sometimes there are a lot of males, so if you have a family with a lot of males, a lot of uncles, you're not going to actually see ovarian cancer, and you're rarely going to see breast cancer, so that's another problem. You have situations where whole lines of families have perished in the Holocaust or something like that. So sometimes you don't get the clues, and you really need the clues to provide context for what might be going on in the family, for what kind of testing to go for.
And we get to Elizabeth. I mean, how much did you know about your ancestry, about your family medical history? Did you have any clues that you should be worried about this?
I had no way of knowing, and there was no sign of it. No sign. It's not that, I had no reason to believe that I had the BRCA gene other than that I am Jewish. That was the only indication that I had. All Ashkenazi Jews should be tested. If you are an Ashkenazi Jew, you need to be tested. That's how it works. And this is not a medical problem, this is a public policy problem.
I looked at a couple of the studies, and there's a study out of UCLA where they tested, I'm sure you guys know about the study, they tested 10,000 Ashkenazi Jewish women. And because of that, they were able to avert 62 breast cancers. That's 62 lives. And when I finished reading that study, I mean, it did beg the question, like, shouldn't we at the very least be testing all Ashkenazi Jewish women? So go ahead, Dr.
You all want to
Robson.
talk?
I just want,
Whoever wants to start
I think
it.
that this is a very important conversation, and the discussion about population screening for cancer susceptibility overall is an important conversation, because this is really going to be the first place where we have a public health application of all the genetic knowledge that we've been gaining over the years. I think the important thing to bear in mind, there are two very important things to bear in mind. The first is that the vast majority, not the vast majority, but the majority of BRCA mutation carriers are not Ashkenazi Jewish. There is indeed, as you point out, an increased, the jargon word is prevalence, of mutations in the Ashkenazi Jews compared to non-Jews, but just because of the differences in the numbers of the populations, most BRCA carriers are not Jewish. And of course, most breast cancers or ovarian cancers are not due to mutations in BRCA1 or BRCA2. So the question about, and there are other cancer susceptibility syndromes. There's Lynch syndrome, which is a colon cancer syndrome that's present in probably also about 1 in 400, and there are a number of others. So the question is that this is certainly a potentially easy target, if you will, for a variety of reasons. But if you think from the big picture about how should we be using the genetic knowledge that we've gained, there are certainly much broader ways that we could be doing it instead of just.
So you're against
So,
testing Ashkenazi?
but wait a
Jews?
second.
That's
So
a bad idea.
Let me use an analogy. When it comes to colon cancer, the recommendation, I guess you call it the public population offering, as opposed, right? Population offering is that you should, and the insurance will pay for it when you're 50. But if you have a relative who is diagnosed with polyps at 37, then you come along and they'll pay for it. So if the risk is, because the risk is greater, right, that you'll have it. So if the risk is greater for a certain population, isn't there not an argument to be made that insurance should cover those who are at greater risk?
I think the question becomes, what's the right threshold? I mean, is there, how do you determine the correct numerical threshold? Is it 1 in 40? Is it 1 in 400? Is it 1 in 800? And how do we come to that number? I'm not saying one way or the other, but you are making an arbitrary decision that this number is worth it and that number is not worth it.
But let's take for a moment
So
that
I
the number
shouldn't
is
have been tested?
let's take for the moment that the number is worth it, okay? And then one of the things that moving forward we're trying to do is say, okay, how do we do this? How do we implement this? How do we make it happen? Because, for example, I have never been once asked in a doctor's office if I'm of Jewish descent, and I have an Eastern European last name. So unless someone asks, I can't have it offered. And there are a lot of things happening at once which are good. One thing is that the cost of genetic testing is increasingly coming down, so the cost argument against testing is going away. So that's good. A second thing that's happening is that there are a lot of efforts being made to make this easier, to decrease the barriers, to get people tested who want to be tested, and to make people know that testing is an option. So Nicole will certainly have a comment about, Nicole has already done a study in the Ashkenazi community offering free testing. We have a study called the Before Study that's launching Philadelphia, New York, Boston, LA, 4,000 Jewish individuals, free testing. I know it may seem like too late, but we are really trying to figure out how to implement this so we can do that.
But the two barriers I'm hearing you say, number one is insurance. And so that everybody understands, right now insurance will only pay if you know there's a BRCA.
No, actually, there are pretty broad criteria for testing, and it is true that they won't test someone who's of Jewish descent who has absolutely no history, but if you even have a hint of anything, they will. And also, again, you can get testing, if you have no history, you can get testing for $250. But in terms of other testing, and it's important to also follow up on Mark's comment, there are a lot of non-Jewish women who should get testing, all patients with ovarian cancer, all women with early onset breast cancer, all men with male breast cancer. So, and all those populations are also being under-tested. So we're working on this, from a number of standpoints, but I think Nicole can talk about maybe her.
Excuse me,
Yep.
Are you disagreeing with me?
Well, I fully agree with you. I think
Are you
that
disagreeing with me? Are you saying that all Ashkenazi Jews should not be tested?
No, I actually didn't disagree
Is
with you.
somebody saying that all Ashkenazi Jews should not be tested?
Nope. I said we need to figure out a way to decrease the barriers to allow that to happen and do it in a good fashion. That's where our barrier is implementing.
But that's changing policy, is it not? And changing
the
protocols with medical
decreasing
professionals.
barriers?
Because right now, if you're, if you are a Jewish woman living in Nebraska and no one ever asks you if you're Jewish and no one ever tells you that this may be an issue for you, it's not going to happen. And policy is one thing, but you actually also, policy is an interesting thing because you can't force people to be tested. You can't. you have to have, it has to be offered to them. And in order for it to be offered to them, you have to have people talking to them about this. We know from a lot of other studies that, in general, people want to hear what their doctors have to say, and they are much more likely to do something if their doctors tell them it's a good idea to do it. So there's all these different pieces that we're working on. I don't disagree with you. We're just trying to figure out how to do it.
I think doctors are likely to do something if they know insurance will cover it.
I don't think it's just that, because in a recent publication, just came out in JCO, they actually looked at a series of women throughout the United States, and of all the ovarian cancer patients that are out there in the United States, all of whom should have already been tested, all of whom would be covered by insurance, 10% had been tested. So it's not just insurance, it's more than that.
What are some of the other barriers or resistance? I mean, there's still somewhat of a stigma, I think, and I think it transcends just the Jewish population, or specifically the Ashkenazi Jewish populations, which are sometimes resistant because of cultural
For sure.
reasons, right? Their marriageability, like a lot of these things, a lot of young women are worried that if they're in their 20s, and that begs a question, Dr. Robson, what age would a woman want to do this test?
So right now, the medical management really doesn't change until age 25. You know, for instance, the risk of breast cancer by age 30 is roughly 1%, 1.5%. So the standard guidelines right now are to start breast cancer screening somewhere between 25 and 30. Ovarian cancer is usually in the mid-30s to mid-40s, depending on BRCA1 versus BRCA2, so that doesn't push you particularly younger. But I do want to, you know, this issue of access is important, and apropos of the question of why not, what are the barriers? There's a qualitative difference between saying, you know, we should be testing apropos of like a vaccination. You know, you show up at age 25 in your gynecologist's office and it's okay, time for your BRCA test now, versus a situation where we should make it available to people much more widely. So for those who do wish to have it. And it's an important distinction because one becomes a sort of, not exactly forced, but a very emphatic kind of, this is what you should do from a public health standpoint. And the reason people don't do this, they don't want to know. And there are people who, for whatever set of reasons, don't want to know the information.
So for me, I'm one person who really wanted to know. So I am Ashkenazi Jewish, 100%, and I am all for population screening for all Ashkenazi Jews. I think it should be offered to all, but I think they also need to be aware that this kind of thing exists, that the 1 in 40 number applies even if there's very little family history. For me, the breaking point came when I said, I want to know because if I'm carrying one of the BRCA mutations, I'm going to be carrying it whether or not I get tested. So I'd rather know so that I can get tested and then I can consider the options that would be available for me. It doesn't pay not to get tested and to ignore that. I think it's the same thing with coming to an educational event. I mean, all you guys are here tonight. It looks like a very full audience, which is great, but what brought you here? And who are the people who are not coming? We should have filled 30 auditoriums in New York, and who is not coming? The people who are turning a blind eye, and they don't think that this is an important issue for them.
But maybe we should just be doing this in front of the American Gynecological Society, too. Because it's an insurance issue, as Elizabeth says, and that's a barrier, but it's also the protocol. And you said it yourself, you've never been asked. You know, there are a lot of young women who have no idea that this is an issue. I kind of look at it as like breast density. I never knew I was at an increased risk because I had breast density because my gynecologist never talked to me about it. Now we are getting many, many states to require insurance carrying it, but if they aren't advised and talked to by their gynecologist, they don't know it's a problem.
Right, and there's ways to ask this too, because if you will, we're asking about ancestry, not religion. That becomes a problem. I have had patients who are Catholic, but actually they're of Ashkenazi ancestry, so you have to ask the question the right way. And also, some people get a little put off when you're asking them if you're Jewish, if you don't clearly explain why you're asking, right? So I think that there are just, these are all things that we can get over, and we should, I am with you.
I think that the priority should be women's health and not all this other stupid stuff.
But you got to get through the stupid stuff to help women. If you just say that these things don't exist, if you say that people are asking women if they're Jewish and they're not, well, we have to get past that.
I really think when I talk to women and I say to them that there's all this weird stuff. There was this stigma about this, and they were freaked out about, like, there might be bad Jewish genes, and what does that mean? And that there was fear about that, and there was fear of stigma, and whatever. And people are just, and you know what women say to me? They say, that's outrageous. How could they think of anything except women's health? That's what women say. Women want to know how anybody could think about anything except women's health. They want to know what's wrong with the people who felt like that.
Is there also a little bit about a fear, and maybe you guys can say, if you get tested and if you're positive, can you still get health insurance and everything? And just address that, because that could be an issue also, a resistance.
I think that that's a concern that people have, but it really hasn't materialized as a systemic threat.
Is there a danger? Are you in danger of not being able to get it because you test positive?
Our experience, and I don't know, Susan and Nicole can probably speak to this as well, haven't had anybody lose health insurance or be denied health insurance because of having had genetic testing. Well, there's always a net. You never know what's going to happen in the future, right?
Well, but you say yet because there's no real protection.
Well, no, there are. So let's be clear. There are several layers of protection. First is the Genetic Information Non-Discrimination Act, which was actually signed into law by George Bush. Now and this prohibits the use of genetic information to be used against you in terms of health insurance and things like that.
And it does not also.
And employment. It does not have a provision for life insurance, and it does have some loopholes in terms of like very small companies and things like that, and federal, believe it or not, federal employees. So there are some loopholes, but in general, GINA has been a good thing, and no one has been kind of prosecuted under GINA. So it was a law that came about even though we didn't really see people having a problem with this, but it's on the books. The other thing is, the Affordable Care Act, which has additional provisions, and I think that the pre-existing condition clauses are an additional help. So what might happen overall in healthcare, I think it's just a little bit uncertain right now, but GINA will remain on the books.
But in the meantime, while insurance is not going to cover a lot of women that should be BRCA tested, BRCA tested, there are some new, less costly tests. Is it Myriad, Invitae, Color Genetics? Talk to us about some of these and how they're playing a relevant role now. Or are they?
Yeah.
So I think in keeping with the theme, the idea of expanding access so that people can make a choice to have genetic testing is really penetrating, right? So a number of companies are bringing the cost of their offerings, even for people who are not covered by insurance, down into what is a reasonable range, although still probably outside the range of much of the American public. So you're talking companies that will offer testing for $200 to $250.
And it gives you the same kind of information as
exactly
the one that's thousands of dollars for the BRCA panel?
If it's covered by insurance, right. It's exactly the same test. It just, if you're paying
Really?
for it out of pocket because your insurance is denied, many of these places will give it to you at a substantial discount. There is a company called Color Genomics, which is a direct-to-consumer company that operates over the internet, where they will offer their test for $199. It goes down by $20 every week. So, and it is the same. It's a 25 gene panel. It covers most of the major cancer susceptibility genes, and is probably nearly as accurate, if not as accurate as.
Right. Your issue with it is that then you don't know what to do.
No, it's just important to understand. So I'm all about, I think anyone who wants to get tested should be tested. They should just know what they're getting tested for and what implication it may have. So the difference is, if you will, Nicole mentioned that the Ashkenazi population has 3 common mutations. That's essentially like having 3 words in a big book which are misspelled. There's 3 particular words. These tests now take literally 30 encyclopedias and do all that sequencing. And so you're kind of getting information about a lot of genes, and some of them are very different than BRCA1 and 2. One of the genes, if you have a mutation, you need to have your stomach removed. So it's just, there's a lot of kind of stuff in there that's like bundled into the 250, which I'm not saying is a bad thing or a good thing. It's just a thing, and people need to kind of understand the information that they're about to get.
So what if you don't just do the go on the internet, sign up, pay your money with PayPal and get it and do the test? What about some of these others? Myriad, I think, is one, Invitae is one,
yeah.
where they're done with a doctor's office, as I understand it, so that you guys, who are the experts, read the results.
Yeah, and Nicole, just so you know how this works, an individual comes in, if they actually meet criteria for genetic testing, which a lot of people do meet criteria for genetic testing. Ashkenazi Jewish women with no family history don't, or individuals with no family history don't. But a lot of individuals do meet criteria. And if they do, they usually pay $0 out of pocket. But it depends on their insurer and which place you can go to. There's many labs now. So since 2013, there's been an explosion of the number of labs and the number of different tests that are ordered. And so we take a family history and order a test to make sure that the genes that we are looking at are appropriate for that family history. Now, I'm not saying that the right thing is for everyone to get detailed, genetic testing. What is necessary is that people get some type of pre-test education where they understand. So we're, again, trying a system where it's a digital health platform or where people are getting information on videos. There's lots of different things that are being tried in order to expedite this process. So Nicole, you.
Right, I want to put a plug in here for someone called a genetic counselor, which is someone who could really help guide the journey, in part through the pre-test education and counseling and helping choose the right test and navigate the insurance process, but especially after testing to help interpret the results, which is something that is not done as well with the direct-to-consumer.
Where do you find a genetic counselor?
And any cancer genetics hospital, clinic.
Or the National Society of Genetic Counselors has a tool on its website, which is literally find a counselor, and you just put in your zip code and it'll tell you.
On our website at bassar.org, we have that same thing, so you can put it in to find someone. But again, these are all attempts to make it as easy as possible for people who want genetic testing to get access to it. So I think these changes have all been very good. The decrease in costs, the increasing access, but we still have these other things that we're working on.
And I think you would agree that we're vastly under testing, right? In this country, we're vastly under testing.
Yes, there's a paper that came out in the Journal of Clinical Oncology in December, maybe the same one that you're referring to, where they estimate that there are 1 million women who have breast cancer who have not been tested for BRCA, and 10 million who are pre-symptomatic BRCA carriers also that have not been tested. These numbers are huge, so we're missing it. There is a barrier. There is more than one barrier. I think we have to identify all the barriers, but at the same time, keep moving along with studies and with increased access in other ways.
When we identify individuals who have BRCA1 and 2 mutations, one of the really important things to do is what we call cascade testing, which is to sort of say, okay, who else in my family may be eligible for this? There, we're really relying on the person in front of us to convey that information, and that doesn't happen very well either. So that would be a situation where you'd think it's obvious that all these people would go and make sure to contact their cousins. Remember, I can't call their cousins. People need to do this. We try to give information and letters, and we give all sorts of things, but it's just getting the sense of, long ago, cancer was a word that was hard to say. Elizabeth, it's not hard for you to talk about this, but for some people it is, and we've got to also break down that wall too. Everyone knows about Tay-Sachs, right? Everyone in this room knows about Tay-Sachs. And so another element of this, which sort of we have been working on, is to really go there and say, okay, you're talking to people about Tay-Sachs. How can the words BRCA1 and BRCA2 not come up when you're talking about Jewish genesis
disease anyway, and does anybody get it?
Well,
so the carrier rate is 1 in 24 in the Ashkenazi population for that. That's one of dozens of diseases that we test for, where both partners in a couple would have to be carriers for the child to have it. This is a different mode of transmission because this is dominant. What we're talking about now is dominant. You only need one partner to transmit it to the next generation. And it's also adult onset. So it's a very different kind of disease. Tay-Sachs is an early childhood lethal disease. It's hard to introduce this into the bigger picture of reproductive testing, although it also impinges on reproductive choices because you may actually want to know your BRCA status so that you can use technology to prevent that status being transmitted to the next generation.
But I also just think it's a touch point. It's an opportunity to discuss this. Even if people don't want to be tested, then it's a time that could be used to talk about it.
Dr. Robson.
Yeah, so and let me just take a step back. I mean, respect to the venue and what we're talking about, but this is not just about BRCA in the Jewish population. This is a general issue
Absolutely.
of susceptibility to genetic disease. It's not even necessarily just cancer. There are lots of genetic disorders for which we now have testing, for which we now have interventions. And so the concept of providing an appropriate family history, an appropriate history about background, so that educated providers can then make the right referrals to genetic counselors for the right testing, that's really the bigger public health picture.
Once you have that test, if you get that test and it's positive, how does that then change forever how they deal with you medically?
Right. So if you have a BRCA1 or BRCA2 mutation, and we'll just start with the women, because obviously we have different recommendations for women than for men. For the women, we know that there's a significant increased risk of breast cancer. So we, at the minimum, start MRI screening at 25, adding on mammograms around 30. We discuss mastectomy, which I'm sure we'll talk more about. And so that's management of breast cancer risk is that, plus you can have some modest decrease in breast cancer risk by taking medications or removal of the ovaries. So we approach the breast cancer management, we get a plan with women, and oftentimes that plan changes over time. If you're 25, you may say, listen, I want to have my kids, I want to do these things, and then I may consider a mastectomy later. For women, for their ovaries, unfortunately we do not have good screening for ovarian cancer. Unlike breast cancer, where if you are getting an MRI, most women are diagnosed at an early stage, and most women survive that cancer. Not all, but that's most. In ovarian cancer, we have no good screening. Most ovarian cancer is diagnosed at a late stage, and many women with late-stage ovarian cancer die of their disease. And therefore, at this current time, the standard recommendation is removal of the ovaries and the fallopian tubes, and that's by 35 to 40 for BRCA1 and for 40 to 45 for BRCA2. So those are the breast and ovarian cancer management. And I don't know, Mark, if you want to take the men and hit pancreas, just so I stop talking.
Well, that's a little gender biased, isn't it? Yeah, I will. So sorry about that. So men are unfortunately at substantially, particularly with BRCA2 mutations, are at substantially increased risk for prostate cancer. The risk of prostate cancer in a man with a BRCA2 mutation is not really well pinned down, but it might be 35, 40%. And as Susan, I think, mentioned during the introductory remarks, these tend to be aggressive prostate cancers. We all hear about the prostate cancer that we can watch and it's never going to cause a problem. Unfortunately, the BRCA2 cancers are not that way. There's an increased risk of male breast cancer. It's not particularly large in terms of what we say absolute risk, the chance that a man will develop a breast cancer during his lifetime, but it's much larger than if you don't have a BRCA2 mutation. And unfortunately, both men and women are at risk for pancreatic cancer and also for melanoma. The risks of pancreatic cancer are under 10%, but still that's a very scary disease. And melanoma is not well pinned down, but fortunately we have skin screening, which allows us to detect that usually early if it's done properly.
I have a lot of questions from the audience, but I want to ask about a couple of things that have been big advancements. Number one, Nicole, PGD. Explain, because once you know you've got BRCA in the family, you have to worry about future generations. Do you want to explain what that is and how it's being used?
Sure. So the technology is called PGD, or pre-implantation genetic diagnosis, and this has been used for about 25 years so far. It actually started in the realm of diseases that may be more prevalent in males versus females and being able to choose males versus female embryos. But basically what happens is you do in vitro fertilization, and then you can test the embryos for, let's say, BRCA1 mutations. Let's say that's what's running in the family. And you can select the ones that are not carrying the mutations to re-implant back into the mom. So you're not making any changes. This is not gene editing, which is a topic for a whole other conversation, but this is being able to look at different embryos that are generated by in vitro fertilization, choose the ones that are not carrying the mutation, implant those so that you're essentially stopping the transmission of the BRCA mutation at that generation.
That in the ancestry in the
For
history
sure.
of the family.
So something that's been prevalent in a family for a very long time can stop at that generation. But the only way to know that you can use that technology is if you were tested and you were shown to be a BRCA carrier, so that you can then test the embryos, or that your husband was a BRCA carrier.
Everybody wants to know about a vaccine. Where do we stand with the vaccine?
Sure. So in years past, people would have thought it was crazy to be talking about vaccines for cancer. But what we've really understood over the last 5 or 10 years is how powerful the immune system is in treatment of cancer. There's now been multiple drugs approved, something called checkpoint inhibitors, which basically cut the brakes of the immune system so that it allows the immune system to be active and attack cancers. And this works particularly well in cancers like melanoma, certain types of lung cancer. What we're learning is that you can now train the immune system to recognize cancers. And so with that, we have started a vaccine program where we've already treated 100 individuals who have had early stage breast cancer or pancreatic cancer or ovarian cancer, and given them vaccines and demonstrated that the vaccine is safe and it does generate an immunologic response. And so our next phase will be to take this into healthy BRCA1 and 2 mutation carriers. Our first phase of the study will just be to make sure that it's safe and generates an immune response. But the hope is that, and it'll take a while to prove that it's effective, but that is the end goal. So it's not ready for prime time yet, but we really are truly working on this and giving it to patients as we speak.
And I do want to ask about PARP inhibitors, because just in January, Dr. Robson, we got one of the PARP inhibitors, Linsenza, is it? Lynparza, which had been used, I guess, for advanced stage ovarian cancer in BRCA cancers, and now it's finally been, and we could have a whole other discussion about the FDA and whether they should be approving cancer drugs, but we won't go there. But they finally did approve it for breast cancer, advanced stages, right?
That's correct, in women who have BRCA mutations.
That's going to be, that's like a huge breakthrough, is it not? Is it,
We're
we're
very
getting
excited.
many more treatments. Go ahead.
We're sort of happy about it. I mean,
I think you might have worked on that study.
Susan and I worked on this study together for, Lord knows how long we've been working on that. So we are very excited about that as an approach. Would you like to know how that works?
Yes.
So,
You're going to get them started now.
No. This will be short. So Susan said at the beginning, what the BRCA genes do is they make a protein that helps repair a particular type of DNA damage. And since most of our normal cells have one normal copy of the BRCA gene, most of them are repairing the DNA damage just fine. But the cancer cells lose that normal copy. And so now the cancer cells can't repair that type of DNA damage. And if you think about it like a stool, the cancer cell loses one leg of the stool. When you give the PARP inhibitor, essentially what you're doing is you're kicking out the other leg of the stool. And so the cancer cell then winds up dying. But the normal cells still have 3 legs. So they're able to stay standing up. And that makes it a very well-tolerated treatment that's specifically targeted towards the cancers that are lacking the BRCA proteins.
And what's particularly cool is that, as we talked about in the beginning, most BRCA1 related breast cancers are triple negative breast cancers. And so in this study, about 50% of the patients on the study had triple negative breast cancers. If you flip it the other way and you say how likely it is for someone who has a triple negative breast cancer to have a BRCA1 or 2 mutation, it's about 10%. So all of a sudden, for those women who have advanced triple negative breast cancer, for a subset of those women, this is now an option. So it's the first non-chemotherapy option for a subset of triple negative breast cancer patients, which is actually really pretty remarkable. And in this study, this drug, which they're pills that you take twice a day, was compared to chemotherapy and was not only better, but people had a better quality of life. So it's really pretty cool.
Absolutely. And how about immunotherapy? Because immunotherapy has been making some real advances with metastatic breast cancer patients, has it not?
Yeah, it has. I think that the really more dramatic advances have been in diseases like melanoma, certain kinds of lung cancer, and there are complicated reasons why that's the case. And so what we're trying to do right now is find the optimal scenario for immunotherapy in breast. It looks like if you use it earlier, it's going to be better, and we're probably going to have to use more combination types of approaches than it's not going to be quite as dramatic as it has been, unfortunately, in some other diseases.
I want to get to a couple of these audience questions. If you remove your ovaries, will it still be safe to take hormone replacement, even if you don't get a double mastectomy, but you're just being monitored for breast cancer?
The gold standard in medicine is a randomized clinical trial where half people get something and half the other people don't, and we don't have that kind of data. But so I have a very pragmatic, kind of real policy kind of approach to this. We have had some observational data that showed that women who removed their ovaries, their breast cancer risk either was the same or went down, and it did not change if you took estrogen replacement back. But I just think of it more this way. You have like a total life of estrogen, and when you take ovaries out, we don't give the same amount of estrogen back as you took, so you net have a lower estrogen level. But really, I want your ovaries out so you don't develop ovarian cancer, and you were making estrogen anyway, so I really take a pragmatic approach to this, and in patients who have not had breast cancer, yes, we talk about hormone replacement therapy. Mark, any additions, or Nicole?
No, I mean, I have nothing to add except that premature menopause is a real quality of life hit for a lot of women. And the surgical menopause, particularly for young women, is really very tough for a lot of people. And so,
but I'm sure Elizabeth will say it's better than death, right?
but
It really wasn't so bad. I mean, it's not so bad.
Some women,
Everybody's
I
different,
mean,
though.
no. I mean, it really is. I think I was expecting it to be like this wretched thing. It's fine.
But for that reason, I think that hormone replacement therapy, given the fact that there's no evidence that it's harmful and can mitigate that very negative consequence in women who experience it, I think it's a perfectly reasonable thing to do.
All right, we got one for the men. What can men with the
I'm
BRCA
gonna answer this
gene
one.
mutation do in order to reduce their risk? Is there something to reduce the risk?
Yeah, I mean, that's unfortunately a good question. There's no really effective studies of prostate cancer prevention, for instance. So I think the main thing would be to ensure that one is getting the rectal exam and the PSA test starting kind of early to mid-40s. Breast cancer screening in men has really not caught fire. But physical exam in men, just sort of feeling on their chest, is often able to detect any kind of lumps that could be a cancer. And there's no screening for pancreatic cancer, unfortunately.
I remember a football player reached out to me and said that he was in a car accident on the LA freeway and went into the hospital because of that. And only then were they like feeling him to see if there had been an injury from the airbag, that they discover that he has breast cancer, and he was mortified by it because he's an athlete.
I think this is an area where the medical community has to be super careful. We've made everything so pink, and the mammogram suites have pink gowns, and the breast centers are all pink. I have plenty of men in my practice, and so we really try hard to take that down a notch, because men get breast cancer too, and it can be a difficult experience for a lot of reasons, including this feeling of masculinity, and they're not supposed to get breast cancer.
And these men also need to remember to tell their sons and their daughters that they are carriers and that they should consider testing too, because there's a 50% chance that they've passed that mutation on to these sons and daughters. I remember a beautiful story that I heard once where a man came in who had cancer, was tested, he was BRCA positive, and he said, "I am so happy I had cancer because I had the opportunity then to be able to tell my daughter, go get tested."
We've talked a lot tonight about the disproportionate risk for Ashkenazi Jewish populations, but someone is asking you, what other populations do we find this genetic mutation in? Is that a fair question, or is it
Yes.
just kind of across the board? Okay.
There is not a ethnicity, race, population that has not seen to have BRCA1 and 2 mutations. So that's why this issue of we test every woman who develops breast cancer under age 45. We test every woman who has ovarian cancer, at least we should. We look for family history. And there are these founder mutations that were referred to. There are other populations that have clear founder mutations. One is in Iceland. So Iceland, it's basically a giant island, and it doesn't have that many people on it, and there's basically one mutation that occurs in that population. So we know of these things, but in general, what's it? Bahamas is another, and just an interesting genetics meets history is that in Mexico, one of the most common mutations in Mexico is one of the Ashkenazi Jewish founder mutations, and the idea is that during the Spanish Inquisition, there were people who migrated to Mexico and, came into that population and basically pretended they were Catholic, but they were really of Jewish descent, and there's 185 del-AG. So there's these interesting pieces, but in general, it's why although Ashkenazi Jewish ancestry is important, family history is really important, and people shouldn't think, oh, because I'm not Jewish, I don't have to worry about it. Nope, that's not the way this works.
So then how do we try to, with the BRCA mutation, it seems like it's more than just finding new treatments. It's the complexity of it is that it's also trying to figure out how to find those people who have the mutation who need to know it.
Yeah, so the way that I've said this recently is that we are moving full steam ahead in a train talking about what we call the actionable exome, which just means that there's like 56 really important genes out there that would change medical management. And the idea is that probably within 10 years max, it may be that everybody is going to get screened for all 56 of those genes. But in the meantime, we can't miss the obvious people, and we're missing them now. So again, these papers that are published that we're not testing these people who've had ovarian cancer or breast cancer or family history or Ashkenazi Jewish. We got to catch, we still haven't gotten all the low-hanging fruit. We've got to get that.
So how are the medical professionals at Vassar, what's their thinking about the best way to try to wrap their arms around and find those people, get them tested? And of course, then that begs the question that once you have that test, there are big decisions to be made. And is that part of the issue too? Are the ethical questions, the big questions that loom as soon as you find out you're positive?
Well, to take that question first, I think someone asked me, oh, do you ever get sick of saying the same thing to people over and over each day? And I was like, I never say the same thing to a person over and over, because for each individual in front of me, there's different decisions about, do they want to have kids? When do they want to have kids? Do they have a partner? There's just so many pieces to this that it's very individualized how women make these decisions. But in terms of how to approach this, I think we're coming at it from all angles. But one big project is this BEFORE study, which is this Ashkenazi Jewish founder mutation project, which is launching in the next few weeks. There's information out there, again, free testing in the Ashkenazi community. There's a lot of effort at, for instance, things like telegenetics to get access to people who otherwise don't have genetic counselors. There's things that I've been working on with Mark called point-of-care testing, which is you just test all these people with advanced pancreatic cancer or prostate cancer with just a video and consent, trying to make it easier for doctors, for patients, and capturing as many people as we can. And yes, we need to do more, but we are really trying to move this forward.
I think what we've really found here tonight is that this is a complex issue. It's a medical problem, it's a policy problem, a protocol problem, it's an insurance problem, and it's an education problem, which is why we thank the Vassar Center for BRCA and the 92nd Street Y and the UJA Federation of New York for this evening. And thank you all for coming, and you can come and join us in the lounge to meet all the panel. Thank you.